He's a 24-year-old male, presented to us in the outpatient department like this. He was in a above knee slab. The history is he had a distal femur fracture about 6 months back. He was operated for a plating procedure. He didn't know the kind of plate. There were some issues. There was some drainage and problem with the wound healing. He was given antibiotics. The wound healed, started again discharging with a purulent discharge. He went to another orthopedic surgeon who explained him, took out the implant, debrided it, and put him in a slab. But his wound again broke down, and that is how he presented to me. This was his X-ray when he presented to me. Any thoughts, Dr. Trikha?
Hello. Yeah. By the time Dr. Trikha is on the line, I will take this. Basically, it's a case of implant osteomyelitis where the implant is now already out, but the osteomyelitis is still there. One can see a sequestrum, the middle fragment. It is totally sclerosed one. So that is the source of infection. One needs to go down, debride that part, remove it, open the medullary canal. One can use a masculate technique. So masculate technique, putting that cement spacer. Either you can put it by using a plate, you need to stabilize it. Either you can use a plate or you can use a X-fix in the form of linear external fixator like a LRS. And do a 2-stage. Once the infection has settled, go down and bone graft it and stabilize it.
So what's your preferred method? Do you do masculate or do you prefer bone transport or what?
Preferred one is the masculate one, especially in this part of the bone.
Dr. Sandeep, I know you are the masculine man. So what will be your preference for such a patient? How much bone will you resect and what will you do?
Again, the resection would be decided by the paprika sign in my hand, sir. That is my go-to sign. So I'll keep resecting till I get a good paprika sign, and it would be a transverse cut. Anything less than 5 centimeters. So we have published, I have a series of around 120 cases where we have published on the masculase technique, and the initial publication was probably of 54 cases, which was published in IJO. And masculase in femur works very well. Anything up to 5 centimeters, 6 centimeters, I'll be happy to do a masculase. If my gap is anything more than 5, 6 centimeters, we are doing what we call as a rail plate technique these days. So 5 centimeters is a cutoff for me for masculase in my hands.
So Dr. Trikha, what is your algorithm, like 5 centimeters, or you have a different approach, or you don't do masculate?
No, we have been doing a lot of masculate as Sandeep has been doing. And what we have found is, as he has rightly said, in the femur where there's a lot of vascular muscles and everything is around, it is still possible to do it. In tibia infections, it takes a lot of issues. The second thing which I have seen and I learned the hard way is the external fixator as a definitive fixator module is not the best one. You will have a lot of issues. I have had failures after 3 years, 4 years. Aseptic, they became aseptic, but there was a stress shielding and the middle part of masculase starts giving a stress fracture, which has been reported, but not that high. And I feel that an intramedullary strut at that time or a plate would have prevented that rather than an external fixator, which we remove after some time. So for this case, initially, yes, you can use a fixator if you want. But once I'm going in for a definitive part, I will put in an intramedullary rod, and then which will reduce my space which I require, if possible. Otherwise, I'll use a plate for that with a flap, whatever coverage has to be there. I will not go as an external fixator for my definitive treatment fixatory modality.
So we have the views from the panelists. So this is what I did. I went in, debrided the whole thing, put in an antibiotic spacer, and put him in a Lazarov fixator. I wasn't brave enough to plan for a nail or a plate because the kind of issues he had and the kind of bone he was having. I knew, now it's proximal 1/3 was untouched. My plate would have to go around that place. And if he got infected, those were my fears. I'm not saying that's the go-to way. But so this is what I did. Any comments, anything different you would have done? Yeah, Sandeep.
Sir, you used a cement. I mean, there are two philosophies to use a cement spacer here. Either you are using it for a definitive masculine, or you're using it for a spacer for a dead space management and local antibiotic delivery. If it is done for that, then I'm happy with this sort of a spacer. But if I'm planning a masculine sort of thing, you're put in a laser also. Most probably you're planning a bone transport here. So if we are putting on a masculine, I wanted to bring up a point that the spacer should overlap the ends to have a good contained membrane, just for the sake of completion of the masculine technique.
Yeah. So as I said, I wasn't planning for masculine, to be very honest. I'm more of a bone transport person. I find it much easier in my hands. So this is how we started. So what are the problems that you foresee in such a patient that you should be prepared for? Yeah, Sandeep.
Painful rehabilitation, loss of knee range of motion, regenerate.
Knee was already stiff. Knee was already stiff.
So that's okay. Yeah. So pain is something which is common issue with the Elizarov in femur, ring fixator in femur. Then bending of the regenerate is another thing which is common, especially if it is more than 6 to 8 centimeter of regenerate. And early removal of fixator before everything is consolidated because the patient so demands. These are the three things which I have faced clinically in my situations.
I fully agree with you. We had a lot of pin problems. I had to change his pins twice. 2 times he had to revisit the OR. But what made me so happy was I told him to do a partial weight bearing, and he comes to me when the bone transport was started, the first X-ray. As is the usual custom in the North India, he walks to me in the outpatient department, comes to my side and touches my feet, and his father says, "Saab, ye 2 saal ke baad aaj chal ke aaya." So that's what gives you the happiness when Elizarov is put, because I was confident I could do the full weight bearing. Not trying to say this is the, a better alternative. It's just what works in your hand. So this is one of the pictures that we wanted to achieve. Regenerator still maturing. The distal part is united. Now, for how long should we keep this fixator on to protect the regenerate? Or any other method that you use, any brace or something? Anybody who is into bone transport of the femur can guide me on what to do at this stage?
Dr. Harpal, how much time did you take to reach this stage?
2
How many
years.
months?
He's been under me for 2 years before
This is the
fixator
picture
removal.
now. This is the picture now.
I removed his fixator in the 25th month.
The regenerate is still not very strong. And in fact,
ये तो बीच का X-ray है. This is in between, but his fixator was removed in the 25th month.
then you must have assumed good strength of the regenerate then. 2 years is a good amount of time.
Yeah, but how? Yeah, Sandeep.
So generally, it is around for femur. It is around anything between 48 to 52 days in our series. Me and Dr. P.N. Gupta we compared both techniques, masculine with bone transport. So anything as a rough guide, it is 1.75 to 2.1 times the time it has taken for the distraction. So if it was, let's say 5-6 centimeters, you would have taken roughly around 2.5 months, 3 months to distract that out, and then another 6 months in fixator. So that should be enough for femur, because femur regenerate generally consolidates well if it is full thickness, as it can be seen here.
Right. So this is how he was after removal of the fixator, walking around. Now, do we protect him in the brace or it's not required?
Not required with this sort of an excess.
He's maintained his length, axis. It's well united. Will you, Dr. Trikha, is it important to see the development of a medullary canal in the regenerate before we start full weight bearing without protection?
Not in my hands. If I can see that it is a good regenerate solid, which is robust, patient is walking without any pain, and the union is there, I would do that. The only thing which I would like to bring about is, in my experience, and what has been different here, as Sandeep has rightly told, that you have used not masculine intrusions for the bone regeneration part, and you have used and combined two modalities for that. This is the beauty of Ilizarov, that you get the bone which is normal bone which is getting regenerated, and the autogenous grafts which we put, unless we have good experience with RIA, because I do not have good experience with RIA right now. The grafts which we use for mascule, they are I would say a hurdle for going beyond a certain limit of centimeters, which is the major drawback of mascule in our hands. Whereas if you see the world literature, they are going till 20 centimeters. Also, the literature has been there. 10, 11 centimeters is not a forbidden task for them. This is an excellent way of taking care, provided that the knee range of motion has already been counseled to the patient, or it was already stiff as it was in your case.
Also, I think Dr. Harpal, the way the cortices have regenerated on both the AP and the lateral X-ray, the thickness of the cortex, it's a beautiful result. So I think we can be brave enough to allow him to move without a brace.
Thank you.